Why we conducted this study? Well, it's a new, interesting agent which already is approved in previously treated patients. It's an alternative to chemotherapy. The drug is called Ibrutinib. It's a kinase inhibitor which targets the enzyme called BTK, or Bruton's tyrosine kinase. So it's been very beneficial over the past years in patients who are previously treated, oftentimes high-risk patients. Many patients who didn't have any good alternatives because oftentimes they were refractory to chemotherapy-based treatments. So for those indications, Ibrutinib already was approved, but this study now is testing the drug in previously untreated patients who are over the age of 65. And it's a randomized study where this drug, Ibrutinib, is compared to something that's considered or has been considered as standard treatment for many decades, chlorambucil. It's still widely used, more in Europe than maybe in the US. So we compared those two as frontline treatment for CLL patients, and the results, I think, are pretty clear, are favoring Ibrutinib. We have better overall response rates, we have better progression-free survival, and we have better overall survival as well. It's an enzyme that's essential to B-cell, normal and malignant B-cell life, and it's very important for what we call the B-cell receptor signaling pathway. The leukemia cells in CLL are very dependent in terms of growth on the B-cell receptor signaling pathway, and the B-cell receptor is a surface molecule. In order to function, it needs to transmit the signals from the surface into the cytoplasm and further on into the nucleus, and for that it needs BTK. So if you block that enzyme, this signaling pathway, which is essential for the growth of these leukemia cells, is turned off, and then the leukemia cells consequently die. And we think that's probably the key mechanism how it works. So the primary endpoint was progression-free survival. And I think to make it relatively short, at approximately 18 months of follow-up, 90% on the Ibrutinib arm were free of progression, only 10% had some progression events, but approximately 50% on the chlorambucil arm were progressing, so there's a wide gap. And that was clearly a positive signal. But a major important secondary endpoint was overall survival. I think those data are also clear. And those are maybe a little more difficult to interpret because there was a crossover. If patients progressed on the conventional chlorambucil arm, after a year later they could cross over to receive Ibrutinib as a salvage therapy. So what we see is the curves separate. The Ibrutinib overall survival curve is almost a flat curve. There are hardly any deaths on that arm. But with chlorambucil, we see some drop-off during the first year, but then patients are allowed to cross over, and then things flatten out for that control arm as well. But there's a clearly significant difference there favoring Ibrutinib. This study emphasizes that Ibrutinib is an excellent drug in the salvage setting where it's already approved, but it also works very well in previously untreated patients. And we are in a situation in elderly patients, we don't want to give intensive chemotherapy-based treatments, intravenous chemoimmunotherapy like BR, like FCR. And now we probably, or we hopefully will have an alternative because these data are so compelling to use this rather than chemotherapy-based treatments. So hopefully this is going to become an alternative. And then we have to discuss with patients. It's a case-by-case decision if this is really the optimal treatment, but I believe from my experience in many patients it's going to be a good choice for many patients, especially elderly patients.